I'm going to get my talk up and talk about the impact of patient-specific implants. And again, this really kind of catalogs like my journey through, my surgical career, my surgical life, and, how I've been able to sort of use new technologies to help my patient population, and at the same time be reflective of, the changes that are being made. So I want to present emerging technologies in the patient-specific implant space, specifically today, unit rods and Aprevo, both of which I've incorporated in my practice, discuss the rationale for patient-specific implants, discuss the impact of AI and machine learning on patient outcomes, and give a few case examples as, I've incorporated these into my practice. So if you're not aware of this, unit is, Medtronic picked up this from MetaKorea a handful of years ago, and it's their adaptive spine intelligence. So it's a comprehensive platform, where you can, import images and, use, database analysis of your patient and, plan, execute, and analyze what happens afterwards. We'll get into that. This is kind of fun because, radiographic parameters are clinically relevant and continuously evolving. And I think back when, we were first starting out, probably a few years in, it was this PILL within plus or minus 10 degrees. And that's a big variation, 20 degrees. And, there's been all sorts of variations of this with age adjusted, the Rousseli classification, which really had always kind of resounded well with me, understanding these spinal morphologies and where curve needs to be, really kind of, was something that caught my eye early on. And, I think it's been sort of the template for my career. And then using the GAP score to look at, pelvic tilt, lumbar lordosis, distribution of lordosis, global tilt, to get the patient proportioned. And then, now we're actually getting a little bit more refined with a target lumbar lordosis with, 0.6 of PI plus 30 and target L1 PA, 0.5 of the PI minus 20, using these as guidelines as to get our correction. So the clinical benefits of sagittal alignment, one of the big things is achieving the harmonious alignment of key spinal pelvic parameters such as SVA, PILL mismatch, and pelvic tilt is one of our big goals of deformity surgery. Patients possessing postoperative spinal pelvic parameters within normative range exhibit improved patient outcomes. And one of the risks of not doing this is the need for revision surgery. And we can see this little just picture on the right of an old Harrington rod construct versus somebody who had patient-specific alignment. And we do know that 62% of the patients remain sagittally malaligned after surgery. Sagittal realignment and clinical outcomes are directly related. SVA improved with unit rods, 81% achieved normative SVA values, and with significant improvement in all key parameters postoperatively. So this has been shown again and again with sort of the unit cases, and we know that once we don't get patients aligned where they need to be, they have up to a 10-fold increase risk of developing adjacent segment disease for even 1 to 3 level degenerative cases. We start thinking about, radius of curvature. In a study of 60 unit rod patients, it was analyzed how the radius of curvature of patient-specific rods differed between patients at different levels. The rods were highly personalized with standard deviations of 40 to 53% from average curves of the typical, prevent rods. And for constructs above and below the L4-5, the rods had 2 distinct curves to account for greater lordosis before L4-5. And that's where, I think those of us who've always kind of bent our own rods, you would be a little bit more thoughtful rather than just pulling a prevent rod out of, the tray from our favorite vendor and trying to get the spine to conform to that. We're not doing the right thing for our patient. So one size does not fit all. And so one of the other things is machine learning prediction of the thoracic kyphosis. So in this study, they looked at 20 adult deformity cases instrumented to the lower thoracic spine of the pelvis to determine the ability of the unit adaptive spine intelligence to predict postoperative pelvic tilt and thoracic kyphosis in uninstrumented regions of the spine. And so when we looked at what the postoperative values were compared to the predictive, they were within very tight p-values. Another thing that was learned about using patient-specific rods and getting better alignment was there was a decreased incidence of rod fracture. And so when we look at this of historic ISSG data of rod fractures in adult deformity cases of being, 9% versus 2.2% with unit cases. And when we looked at these in conjunction with a PSO, where there's a 22% incidence of rod fracture versus 4.7% with the unit rod. So that was actually kind of interesting to look at as well. And then when we look at the average difference from target angle, so in this study, we asked experienced spine surgeons to contour rods with a French bender to 40, 60, and 80 degrees. And what happens if you just give a deformity surgeon a rod and say to bend it, their ability to get the rod bent to that angle varies highly. Whereas if you have a template, a paper template with it drawn out, that becomes a lot easier to obtain. So let's jump into the UNID ecosystem here. So this is a concierge service with biomedical engineers to help surgeons simulate your surgical strategy. AI-powered models of estimated postoperative spinal compensation using predictive analytics, and patient-specific implant custom to the surgical case plan. And so this process will import images. It'll go through a planning phase and into the predictive model. A lot of parameters such as preoperative lumbar lordosis, thoracic kyphosis, pelvic incidence, pelvic tilt, SVA, age, gender, weight, height. And another thing that I incorporate into this is sort of spinal flexibility. So looking at the thoracic spine with a CT, understanding the patient's ability to relax these segments or change their thoracic morphology after surgery is also important to put into this. And even in the degen model, leveraging AI and machine learning to drive a new degenerative algorithm that predicts key compensatory mechanisms of the lumbar spine 6 months postoperatively. And so we'll look at changes in the lumbar lordosis and the non-instrumented levels, changing pelvic tilt and change in sacral slope. And it requires, x-rays that show L1 to the femoral heads in any lumbar fusion that includes a sacrum. And so this is how it works. And this is the kind of cool part about it, is it's an iterative cycle. And so this cycle gets actually more powerful the more you use it. And the more people use it, the more cases that get put into this. And so it starts with image analysis and case simulation. And oftentimes with these simulations, early on, it'll kind of look at your strengths as a surgeon. Are you an all posterior surgeon? Are you an anterior surgeon, a T-lift surgeon, a lateral surgeon? And it'll go through various iterations of the case, and you can actually go back and forth with your software engineer to opine and say, I think I need more of this, less that, and you can volley plans back and forth. Once it's agreed upon, patient-specific implants are delivered. Intraoperatively, you have to reconcile the case. Afterwards, images are then collected, put back into the system, and this is where the machine learning takes place and future predictive modeling improves. And so this is just a case with a deformed patient, and there was a handful of different surgical options that you could potentially employ with higher grade ostomy, lower grade osteotomies, ALIF or TLIF, and then you can work on sort of what plan you think would be best for this patient given their unique situation. And so with this, now I think there's probably over 10,000 surgeries and up to 200 surgeries a month. Rods are available in 3.5, 5.5, 6.0, titanium, cobalt chrome, MIS, and tapered rods. And then afterwards, the great part about this is you can compare your pre-op plan and post-op images and parameters for the individual patient. And, advanced analytics and visualization of outcomes of the surgery are all presented for you, and you can see where you are with obtaining your data. And then what I'll do is I'll sit and meet with my engineers, and we'll go over cases, and we'll kind of figure out ways that we can hopefully optimize, patient outcomes in the future. So this is great. We have these little powwows. I'm going to skip over some of these slides, and I'm going to kind of do a case presentation here. So this was a 64-year-old female with a remote history of an L5-S1 high-grade slip, surgically treated with a gill procedure and an L4 to S1 fusion. 2014, she underwent an attempted L2 to L4 posterior instrumented fusion, and I couldn't find the op notes, but they ended up dropping that. She had a kind of a number of different medical comorbidities, including diabetes, and she had somewhat of an extensive surgical history, on a fair number of medicines by the time I saw her. And one of the important things was her morphine milliequivalents were on the high side. In 2016, let's see, she was evaluated by another surgeon. I just happened to get the older pictures, and she underwent a T3 to the pelvis. And within 6 weeks, she exhibited proximal junctional failure with a UIV +2 of 24.5 degrees and a T1 slope at 51 degrees, and no further actions were taken. She was just observed and kind of lost to follow-up. And then in 2020, she was seen by another surgeon, and she was noticed to have like increasing angulation and failure. 2021, it got even worse. And later in 2021, it was even worse with a 56-degree angulation above there. She developed wound drainage at the cranial end of her incision with prominent spinal instrumentation. She was seen by neurosurgery plastics and ID at an outside facility. She underwent IND, removal of the failed upper instrumentation, and then she was placed on antibiotics and followed by ID. Her cultures grew out staph epidermidis. She was ultimately referred to me at UCSD for management of her deformity. She was found to have worsening myelopathy and increasing incidence of falls. Previous incisions that were closed by plastics were well healed without complication. Her ESR and CRP normalized, and she was cleared by ID for surgery, and her A1C was well controlled. So this was a case, that I looked at, and I ended up measuring this out, and I felt that she was an appropriate candidate for like a T3 VCR. And so this is my typical routine with planning these cases and looking at this. And then I put it through the unit platform to see what this came up with. And it came up with, a transitional rod. And then some of the key things, let me go back to this. Let's see, where did we go? I lost my slide here. Was this. I think the meat of it was the T3 VCR needed an anterior height of 27 degrees and an angle of 0 across those end plates, as well as some low-grade osteotomies above and below. So my surgical plan at this point was stage 1, exploration, obtain cultures to make sure there wasn't any residual infection, remove the instrumentation from T5 to T10. If the gram stain was negative, then replace instrumentation, occiput to T10. We'll talk about the occiput in a minute. And then perform grade 2 osteotomies at a number of levels and temporary rod her, and then wait for the final cultures to come back. And then stage 2 was bivector traction, deep irrigation, T3 VCR with my set goals of anterior height of 27 millimeters, expandable cage, to sort of grow the anterior column while shrinking the posterior column to avoid cord kinking. Use specific deformity heads on the screws T1 through T4 to allow lateralization of a satellite rod across the VCR site to detether this from the primary construct, and then use unit rods run medially to the VCR rods. Where do we go here? So this was stage 2. So I think the key things for this were like placing the chest pad at T910, putting her in bivector traction. So she had one vector, angling up this way, which was put to weights. The second vector, I used the face pillow, and then I used rolled towels as shoulder supports to help lift that portion of the chest wall. Here's intraoperatively, so you can see I have my PSO rack across the VCR site. There's the expandable cage, the inserter, and that's what this looked like afterwards. And throughout this whole process, I was doing intraoperative reconciliation with fluoroscopic images to measure the anterior height, measure the angles across the VCR site, and that was the final picture. And then afterwards with her, I avoided ICU admission. Her morphine milliequivalents dropped from greater than 240 to less than 90. She was neuro intact. She went home on post-op day 3 with her I-band dressing and her drain. She had an Aspen at all times except for showering and meals, and a CTO for ambulation. And she came in at 2 weeks post-op to get her drain removed and her dressing removed. And she's done quite well, and I've seen her back now for her 1 year post-op, and she's actually doing really well. And that was sort of like my intraoperative or my post-operative reconciliation was at anterior height and those angles across the VCR site. So I think this was a case in the past. I would kind of go the best I could with like what I thought the patient would need, and I think I've had failure in the past of not getting patients lined up, but really sort of using that rod as a guardrail of where I needed to be, and specifically understanding what her intraoperative measurement should be. So again, that was sort of my plan. That was my post-op, and that was a fun post-op reconciliation meeting with my team. So now I want to change gears and talk about a prevo. So we know that 40% of adult spinal deformity surgery has high complications, up to 46%, and 26% require revision surgery. And malalignment is the leading cause of poor outcomes, and alignment is achieved only in 68% of the time. There's a big difference between the stock implants that we typically use and patient-specific. The stock devices are mass-produced with scripted shapes and sizes. They don't necessarily fit patient anatomy. They're not integrated into the overall realignment plan. There's minimal coronal correction. There's point loading on the end plates and high posterior rod stress. Some of the benefits of using patient-specific implants, they're actually designed and built specific for that patient. They fit the patient's unique anatomy. Deformity correction can be built into the device, particularly with coronal correction. You can grow one side of the spine with these fractional curves or these trapezoidal bodies. And then the other big thing is you increase contact area. So you're actually, the implant's going to match the patient's end plate topology. So it reduces stress concentration on the end plates, and it actually lowers posterior rod stress. And so these are built on demand using patient imaging, which I import both X-rays and CT. So this is modeled off of the CT imaging. And so again, similar to the unit, we have little back and forth with the engineers to help optimize our plan, and it provides anatomical fit with deformity correction built into the device. And I have a few kind of thoughts about that I'll share at the end. And they're designed to help us achieve our surgical plan correction. And so these are available in ALIF, interfixated ALIF, TLIF, as well as lateral. And so we know that end plate conformity matters. And so this was a study sort of looking at the cage end plate interval. And this is actually just looking at a way to sort of optimize that with a stock cage. And if you kind of look at the stock implants here in this picture on the top right, we can see there's these big gaps where there's poor contact. And this was just looking at a better way to fill the disc space. We know that when we compare a stock implant versus an anatomical implant, and we look at the stress load, so the picture on the top left is the inferior end plate and the superior end plate below, and we can see that by using this anatomical implant that all the load is decreased. And so this was a cadaveric analysis comparing patient-specific interbody devices to stock devices for achieving the planned correction and the treatment of adult spinal deformity. And so with this, using stock devices, missed target coronal correction by 7.1%, under-corrected lordosis by 18.5%, and produced 11.9 millimeters of overcorrection in posterior height. Whereas with custom devices, Coronal angle correction was within 0.4 degrees. Lordosis correction was within 0.5 degrees, and posterior height within 0.2 millimeters. This was one of the first presentations with this, and this was a retrospective study. And this was looking at 39 patients with 67 Aprevo implants, and the objective was to analyze pre- and post-operative spinopelvic parameters in the patients receiving custom interbody implants for adult spinal deformity. And this concluded that target global and segmental spinopelvic alignment is achievable within near range using Aprevo patient-specific implants. And so how this works is similar to the UNID. You know, we start with preoperative imaging. Surgeon input is important with this. There's a proposed plan, and this plan can go back and forth. I usually do weekly video meetings with my team to go over sort of the upcoming cases. Once approved, implants are made and delivered. These are produced, and then during surgery, those of us that have used it, you know, when you put this in, it's almost like a lock and key type thing. It sits kind of right in the intended spot, and it really has like good tactile haptic confirmation that it's where it needs to be. And then it's like you can do your intraoperative analysis to making sure your plan is reconciled. And so with this, you know, like it's really nice. We have an app. I have an iPad, and I can also do it on my iPhone. You can go through, you can look at each planned cage. You can look at the pre and post-operative images and make any plans as you need. So this was a post-operative radiographic assessment and plan confirmation. And this was looking at 53 patients with 94 implants and all levels. The plan correction was achieved and maintained. Let's see. And this is similar to the UNID thing where you start with your, you know, sending your images over, a plan is constructed, you can approve the plan, it's produced, you do your surgery, and then the post-operative pictures go back into the system, and this is where the machine learning takes place. And the more cases that go in, obviously it becomes more powerful. This is a case example of pre-op CT and radiographs. Surgical goals and key spinal pelvic parameters were measured. This was not my case, but this was determined to be a single level ALIF, and we can see that with the modeling, these are the expected changes. This is what the implant and, you know, modeling looks like. Spacers are delivered, they're implanted, and so this is sort of the goal. And that was the plan, and all of those were achieved in this case. And I'm going to go over a couple of my cases here. This was a guy with a bow type B curve that I actually used UNID and Carlsmed on. So he had a pretty significant deformity. And so with my UNID plan, this is, you know, what we had come up with. And this was kind of the expected changes that we would achieve with surgery. This was my Carlsmed plan. I had planned to do a 2-level ALIF on him. And the UNID plan also included potentially laterals, particularly to 3-4, since it was rigid but non-ankylosed. And that was sort of the reconciliation. And these were the cages. And this was an early on case I did. And this was the modeling we had here with pre-op to post-op. And these were my pictures afterwards. And I think I learned a lot from this case. I ended up not doing laterals, but I did a stock ALIF above. Ultimately, I got him aligned pretty well. This was one of his immediate post-op pictures. And I mean, being technical myself, I think I probably could have had a little bit more lordosis, although I think my UNID reconciliation was pretty good. I think he probably still could have been a little bit better. This is my post-case analysis of looking at the pre-op versus planned, the pre-op versus post-op, and then the plan versus post-op. And those green and blue rods on the right symbolize where he was intended to be and where he wound up. So they were within pretty much close measure. And so in summary, through data collection, machine learning, and a continuous cycle of improvement is created through database enrichment, predictive analytics can model reciprocal changes with various treatment plans and help to mitigate untoward complications such as PJK, rod fracture, revision rates. Patient-specific implants can serve as the guardrail of successful surgery, but I wouldn't rely on them completely. And sort of my lessons learned thus far have been facet morphology is critical in harnessing the power of the patient-specific inner bodies. Predictive modeling may underestimate the segmental flexibility, and oftentimes grade 1 and grade 2 posterior column osteotomies are required to achieve the desired correction. And that's where being sort of nimble on your toes intraoperatively and assessing your correction and determining what else you need to do in the back is nice. Intraoperative image reconciliation really is critical into achieving your plan. And this is a case I did recently, and I think this kind of shows kind of like my sort of evolution with this. This was a 64-year-old female who was referred to me for deformity. She had some leg weakness along her concavity and some sensory changes. And this is sort of her images, her SRS 22R. Overall, she was a 2.4 out of 5. And here are her pictures. So she was a pretty deformed gal. This is my unit plan on her that, we put back and forth and came up with. Of interest, she was rigid non-ankylosed up in the upper lumbar spine. And so we had talked about doing releases here. I know Greg's kind of gotten away from doing a lot of laterals. I'll still use them in the rigid non-ankylosed segments. And so this was sort of the plan we came up with, looking at kind of all my angles and what was planned on this lady, and then looking at her sagittal parameters. What were my goals with this surgery? So these are all critical. With these patients, I had bending pictures, and you can see with her lateral bending, this is a pretty rigid segment. Also on CT, those segments were rigid but non-ankylosed. And you can see she had sort of the bridging osteophytes here. And for me, I still like to do the releases on those. And, some folks, T-lifts are favorable in their hands. I still, harness the power of lateral surgery for these. This was, my Carlsmed plan with her, sort of looking at, what it would be pre to post. These were the implants that we had created, and you can really see how these implants on the coronal end really fit and conform to the end plate topology. So we're not getting point loading, and I'm not having to do ACRs like we did before. Some intraoperative pictures of sort of the changes that take place, loosening these segments up, getting in here. And then afterwards, this was her in between stages of the surgery x-rays. And then here were the stage 2, and this was her intraoperative T-bar, showing that I got her, coronally aligned. And then here she is with her post-op picture. So I was pretty satisfied with, how her case turned out. And then here was her sagittal pictures, looking at her L1PA and T4PA. And those were dialed into, our planned objectives also. And there she was in her post-op picture. So I kind of want to say thanks for letting me present this. I think it's a really interesting kind of place we're at in spinal surgery with using these technologies. And despite how powerful they are, as we started out this whole conversation, nothing sort of, I think, exceeds like us as surgeons being able to have ultimate control over what we're doing. And you need to know the power of what you're using, and you can't just follow it blindly. I'm going to flip back over to this and stop sharing my screen. And at this point, I'll open the stage for questions.
Thanks, Don. This is Stephen. I wonder, with having the engineers on board for the unit planning and the templating, have they helped you come up with ideas or plans that just weren't even on your radar?
Yeah, I definitely think so. It's always been interesting looking at sort of the unit plans with things that come up. I'm like, wow, I didn't really think about that. Or I think the other thing is I've probably transitioned to doing a lot more PSOs than I had in the past. Whereas, like we talked about on Dr. Eastlack's talk last week with MIS, where I used to probably do a lot more ACR surgery, and now it's really helped me dial in my correction, to probably lower levels where it really needed to be. So it's helped. And then I think with the interbodies, it's also helped. Even with some of the degen cases I've done, it's been like, yeah, well, I didn't think I was going to get that, but I have. Who else?
I got a question for you, Don, about the PSO data.
Yeah.
Was that legit head-to-head two-rod constructs, or
No, it wasn't. I don't think they separated that out because we do know that looking at 2-rod versus 4-rod, there's a huge difference in reduction of PSOs. So that was all the historic data. And I know that like with my PSOs, I always do a 4-rod construct, even with unit rod. And it was interesting. Greg and I were at a meeting a few weeks ago, and it was a lot of the guys like Rusely was there and Chernovsky was there, and they were, Chernovsky was saying that he doesn't use 4 rods over his PSOs, using sort of, their SMIO rods, and using, a posted system which doesn't allow the flexibility in the tulip head. So I think there's, a lot more comparison that needs to be done on those.
Got it. Is it, in terms of planning for the satellite rods that we use for PSOs now, the deep versus superficial rod, is that a challenging process with unit, or can they plan around having that superficial overlay?
No, they can. I usually just run my like main rod down the middle, and I'll do my satellite rods on the side. So I'll specifically plan those screw trajectories with a more lateral to medial approach, and use favorable screw head tulips to accommodate that. So I've done like a bunch of PSOs using that kind of protocol, but I haven't had an issue with the unit rods with it.
What I would assume you could plan it to be a less prominent curvature, though, right? I mean, that was one of the. It wasn't just the 4 rods. It was creating a softer, less curved rod, the long rod, so that there was less stress riser in the rod.
Yeah, absolutely. That's a big factor as
You
well.
could plan that, all right.
Yeah. Yeah, and it's more harmonious. That curve is really like nicely contoured, tapered without sort of that abrupt angulation with notching.
Don, it was a great update, especially for me to see how things are coming to. And I think at the end, it all depends on that specific patient's correctability of the deformity. And that's what, I totally agree with you that, these things are improving, and at the end, you have to have control. But, in the past, I learned from Mark Asher how to bend the rod, and I think we did all those adjustments based on the correctability that we could achieve at the time of surgery. And I think with all the AI data and things that we're learning, know age adjusted things that is still not complete, but it's getting better. And my question is, what do you think? Now we're in the stage that what percentage is pre-made, and with all the cost and everything, and what percentage still depends on surgeon at the time of surgery and adjustments that we do. And my concern sometimes is with less practice in adjusting, during the surgery and just applying the art of surgery, the new trainees are more and more dependent on the AI and how, things that they give to them, and how they can sort of balance this with what they learned at the time of surgery, with doing the surgery and operation.
Yeah, I don't think anything replaces sort of that intraoperative experience, bending a rod and getting the patient to where you need to be. And sort of what I do is, it's not as though I just drop the unit rod in, but I'll actually do sort of all my typical stuff with temporary rods and situ bending, gradual, cantilever maneuvers, compression, distraction, and so forth, and get the spine to the area where I need it to be. And I'll actually lay the unit rod in and use it as a template to be like, well, that's where it needs to be. What else do I need to do? And then do sort of my heavy lifting with temporary rods, and then one by one replace them. So, and it's not much different than, in a sense, what I'd done previously. That had always been my kind of technique I'd use in the OR, and then I would ultimately take my final bent rod that I would hand bend and put it in, and hopefully get the patient to where it needs to be. So I think it just gives me a little bit more understanding of where things need to be. But there's the things that I think the patient-specific rods don't take into account is metal deflection. When we ask the spine to conform to the rod, but sometimes the rod will give and conform to where the spine is, and they meet somewhere in between. And then I think the other thing is, these rods don't really, at this point, take into consideration your coronal correction, right? They don't really work on that. And then, another thing that I don't think they do, particularly with the AIS cases where we do differential rod bending to leaf spring to push down and pull up the spine. I mean, you get two rods that are the same shape, right? There's not a right and a left rod. So, I don't think the technology is there yet. So again, I think there's value to it, but it doesn't replace experience and learnedness. And we all kind of venture out on our surgical journey of getting better, and I think it is that reflection and being critical of ourselves. Like, I like beating myself up over my cases and not getting things where I need to be, and I'm always thinking about how to do things better. But I'm excited to use the technology, and I hope the trainees on the call come out that they very cautiously incorporate technology into their practices. Don't rely on it fully. You still have to be a surgeon. And me, I'm so glad that I have the roots of an open freehand surgeon, because I can always do that.
Those are very important points, Don. Thank you.
Thank you. All right, everybody.
Good job, buddy.
Thank you, Don. Appreciate it.
Yeah, that was a great talk. Thank you.
Everybody have a great Monday. We'll see ya. Bye.